Hello, doctors, and welcome back to our guidelines videos again. As some of you asked me to do the APLS guidelines from the Pediatric UK Guidelines 2024. So here we go. We have a couple of pages here, which is summarizing the APLS in a nice way and in a concise way, okay? So the first one is talking about cardiorespiratory arrest, how you can manage or how you can deal with this situation. So first of all, you have to when you face such situations, you have to start something basic, so basic. You have to stimulate the patient to assess for signs of life and then call for help, okay? Establish the basic life support. You will go by ABC, which is airway, breathing, and circulation. Connect the ECG monitor, identify rhythm and follow the algorithm. We will have a look on the this algorithm later. Okay, and you have to check out the airways, control the airway, ventilation. If the patient need intubation, for sure you will intubate. Obtain vascular access, peripheral or interosseous, according to the situation. Change person performing chest compression every few minutes. So you have another people helping you out when you call for help for the team around you. So you take, the resuscitation, the cardio, the chest compressions in turns with other person, okay? So when you go in terms of airways, so you have to inspect the mouth, have a look on the mouth, if there's anything there, okay? Apply suction if necessary. Use either head tilt or and chin lift or jaw thrust. That's what we know so far. Or nasopharyngeal airways is important. If you have one, just place it. Okay, once you make sure that uh, the mouth is clear. Okay. Just 1 second. All right. If the patient airway not achieved, consider intubation, laryngeal mask, or cricothyroidotomy. Okay. So whether you start with intubation, you put a laryngeal mask, or at the, your final decision for using a cricothyroidotomy, that's your last choice. Breathing, self-inflating bag and mask with 100% oxygen. Ventilation rate for unintubated patient, you're gonna use a 2 inflations for every 15 compressions. So that's a chest compression for 15 compressions, then 2 inflations, okay, for unintubated patient. If he was already intubated and tube in place, that's 10 to 12 per minute with continuous compression. So that's 10 to 12 per minute with continuous compression. So chest compression is going to be continuous, okay? Consider foreign body or pneumothorax if there is no any response in his breathing, there is no good movement of the chest wall while you are doing the CPR. So just consider there's a foreign body stuck in there, or there's a pneumothorax on one of the right or left lung field. Okay, circulation, like cardiac compression rate, 100 to 120 per minute. The breast lower half of a sternum by at least 1/3. Push hard, push fast. Okay, peripheral venous access 1 to 2 attempts, less than 30 seconds. So you have to be so quick, actually, as so fast, you know, 1 to 2 attempts maximum in less than 30 seconds. Interosseous access 2 to 3 centimeter below tibial tuberosity. There's interosseous infusion guidelines in separately in this book. We can have a look, you know, one of, you know, in other video. Use ECG monitor to decide between a non-shockable rhythm and a shockable rhythm. A non-shockable rhythm asystole or pulseless electrical activity, or a shockable rhythm, which mean ventricular fibrillation or pulseless ventricular tachycardia. We have the algorithm here for managing these rhythms. Follows. If arrest rhythm changes, restart algorithm. If organized electrical activity seen, check pulse and for signs of circulation. So we're gonna have a look on this algorithm, so don't mix up now, okay? In this timetable, we have the adrenaline dose or for asystole, which many of you are familiar with these doses, you know. We have the IV rapid bolus or interosseous, okay, IV rapid bolus. According to the age, less than 12 years to adults age, okay, so less than 12 year, that's 10 microgram per kg. The adrenaline bolus, that's 1 in 10,000, okay? 12 years and above, which is 1 milligram, okay, of which is 10 ml of 1 in 10,000 adrenaline vial, okay? Initial unusual subsequent dose, if given by interosseous route, flush with sodium chloride 0.9. Okay, so that's very tiny, and I think most of you familiar with these doses. Many of you have used this before. Okay, so this is the algorithm we have been talking about in the previous page, which is like organizing the steps, you know, stepwise, so you can be organized and you know what you're gonna do next. Okay, so first of all, we have mentioned that you have to start with the safety checkup, which is approach with care, free from danger, stimulate the patient, just talk to him, start to stimulate the patient. Are you all right? Hello, hello, do you hear me? And stuff like that. You have to shout for help, you know, if there's any people around you. The paramedics has arrived to shout for help. Start with ABC, basically airway opening maneuvers that we have mentioned before. Look, listen, and feel. 5 rescue breaths, and this is your first step. Check for signs of life and check pulse. Okay, is he still alive or not? Take no more than 10 seconds for this step. For children less than 1 year old, you have to check pulse in the brachial artery, okay? More than 1 year, just you have to palpate the carotid for any pulsation, okay? Then you're gonna start CPR, 15 chest compressions for 2 ventilations. Then assess the rhythm, you know, it's accordingly, which is shockable or unshockable, as we have mentioned before. If you have VF, which is ventricular fibrillation, pulseless ventricular tachycardia, you will go ahead for DC shock, which is 4 joule per kg, with high flow oxygen, IV or interosseous access. If you were able to intubate, just go for intubation. Together with 2 minutes CPR, okay, and you have to assess the rhythm again. And you're gonna do the cycle again if you still have a pulseless ventricular tachycardia or shockable rhythm, okay? In here, you have unshockable rhythm, which is asystole. You're gonna continue, keep going with the CPR for 2 minutes and then GSS again. Okay, together you're still having the high flow oxygen, the IV access or IO access with intubation if that's possible. Return of spontaneous circulation if he is like responding to your resuscitation. So you're gonna go to the post-resuscitation management, which is according whether he responded after a shockable rhythm or he responded after unshockable rhythm. If the patient was shocked, okay, and he started responding to your resuscitation, okay, and the DC shock you have conducted before, so you have to give adrenaline after the third DC shock, adrenaline after the third DC shock, and then every alternate DC shock, okay? That's 10 microgram per kg IV or interosseous, according to the patient age, okay? Amiodarone after the third and fifth DC shock only, 5 milligram per kg IV or interosseous, okay? So that's the post resuscitation management. If was unshockable rhythm, okay, so you'll give adrenaline immediately and then every minute, okay, and then every 4 minutes, every 4 minutes, 10 microgram per kg IV or IO, okay. Consider for HS and for TS hypoxia. So that's, to make it easier for you to remember. Consider for H's and for T's, okay? You have to think about hypoxia, hypovolemia, hyperkalemia, hypothermia, tension pneumothorax, which is maybe the cause of hypoxia, tamponade, cardiac tamponade, which is maybe causing hypovolemia, toxins, which may be the cause of hyperkalemia, and thromboembolism also you have to think about. If signs of life, check rhythm. If perfusable rhythm, check pulse, okay? So you have to keep checking the rhythm and pulse from time to time, okay? So this is the guidelines 2024, okay? The next page, now they are talking about the defibrillation process in details. Just to have a look quickly, saying here use hands-free pediatric pads in children, maybe use it anteriorly and posteriorly. Resume 2 minutes of cardiac compression immediately after giving DC shock without checking monitor or feeling for pulse. Briefly check monitor for rhythm before next shock. If rhythm changed, check pulse. Adrenaline and amiodarone are given after the third and fifth DC shock, and then adrenaline only every other DC shock. So that's adrenaline amiodarone after the third and fifth shock, okay, a DC shock, and then adrenaline only every other DC shock. Automatic external defibrillators do not easily detect tachyarrhythmia in infants, but may be used at all ages, ideally with pediatric pads, which attenuates the dose 50 to 80 joule. Okay, parental presence. Evidence suggests that presence at their child's side during resuscitation enables parents to gain realistic understanding of efforts made to save their child. They may subsequently show less anxiety and depression. Designate one staff member to support parents and explain all actions. Team leader, not parents, must decide when it is appropriate to stop resuscitation, okay? When to stop the resuscitation, when you are going to feel that you need to stop the resuscitation. No time limit is given to a duration of CPR, no predictors sufficiently repose to indicate when attempts no longer appropriate. Cases should be managed on individual basis dependent on circumstances. Prolonged resuscitation has been successful in hypothermia, where the body temperature less than 32 centigrade, overdose of cerebral depressant drugs, for example, intact neurology after 24-hour CPR, discuss difficult cases with consultant before abandoning resuscitation. So in summary, the CPR is only like prolonged CPR. Resuscitation is successful, or resuscitation in general, in cases of hypothermia and overdose of cerebral antidepressant drugs. Also, you have to consult your senior or your consultant on the timing of cessation of your resuscitation. Post resuscitation management, identify and treat underlying cause. You have to know the cause of this, arrest, by monitoring heart rate and rhythm, oxygen saturation, CO2 monitoring, core and skin temperature, blood pressure, urine output, arterial blood gas and lactate, central venous pressure. Something you can request at this point: chest x-ray, arterial and central venous gases, hemoglobin and platelet group, and save serum for cross-matching, sodium, potassium, urea and electrolyte, clotting screen, blood glucose, liver function test, 12-lead ECG, transfer to PQ, hold team debriefing session to reflect on practice. All right, that's the cardiorespiratory arrest APLS management, which is in 3 pages. Thank you for watching. I want to keep this guideline video short, so I'm gonna record another one, which is the part 2 for this video in the next session. Thank you for watching. I wish you enjoy this video and keep supporting the channel so we can keep going on up-to-date guidelines. Thank you.